in crisis and high utilizer care. My name is Marianne Dyer, Adult Redeploy Illinois Program Director at the Illinois Criminal Justice Information System. This webinar is part of the Illinois Data-Driven Health and Justice Project. Illinois has joined a national initiative to find ways to use data and share information across systems to better identify and address the needs of people with complex behavioral health issues who cycle through emergency departments and jails. These individuals are sometimes referred to as superutilizers or high utilizers. The purpose of these webinars is to provide a foundation of knowledge about superutilizers to facilitate productive conversations about how to intervene earlier for more positive and less costly results. This webinar will describe trauma and trauma-informed care and its impact on physical and behavioral health. And it will introduce Lake County's Crisis Intervention Team Training Program, which provides law enforcement officers with tools to more effectively respond to mental health crises. Dr. Boccellari will present on the following. What is trauma? Trauma-informed care. How this relates to the superutilizer population we are looking at with DDHJ, and provide an introduction to the Trauma Recovery Center model. Sergeant Kaiser from Lake County will present a local example featuring Lake County initiatives to expand crisis intervention team training and how this relates to the county's superutilizer population. Our learning objectives for this webinar are 1, to understand the impact of trauma on behavior and health outcomes. 2, recognize the effectiveness of trauma-informed care. 3, hear how law enforcement can apply crisis intervention team training and trauma-informed care to deal with superutilizers. We'll start now with Dr. Boccellari. Dr. B?
Yes, I'm so happy to join you all today. As mentioned, I will be talking about how trauma affects health outcomes and how it increases high-risk behaviors. I'll be talking a little bit about the prevalence of trauma and also the importance of creating trauma-informed systems of care. And I'm just trying to move the slides ahead. One second. Okay, we're back on track. So let me just start by just coming up with a very broad definition of what is trauma. So trauma is not an event itself, but rather, oops, my slides are moving back again. It is not an event itself, but rather a response to an experience that is so stressful that it overwhelms an individual's capacity to cope. When we talk about trauma, it could be anything from surviving an accidental injury, a mass casualty, a natural disaster, but also very importantly, surviving a traumatic, violent event. So this is a very, very busy slide, but let me just mention that when someone is exposed to an extreme trauma or a threat of extreme trauma, the brain goes into survival mode, and the brain begins reacting in a very reflexive way. And so you end up having the trauma itself, and the brain, in a very primitive way, it's in survival mode. It's going to go into, you have 3 choices basically. You can fight, you can flee, or oftentimes the person may just freeze in place. And what ends up happening, the brain, in order to deal with this trauma, begins to put out a whole cascade of neurotransmitters and basically floods the body with adrenaline and also cortisol. And one of the research ends up suggesting that after a traumatic event, the brain may actually become trained over time to maintain a fight or flight response, and that in some people, a persistent state of hyperarousal may occur, and this can actually lead to permanent physiological changes. For example, we know that after trauma, that cortisol levels and glucose can remain disturbed, and we know that cortisol regulates the immune system, and that blood sugar can influence mood and cause depression, and it's actually thought to be connected to some of the long-term changes that the body undergoes in times of overwhelming stress and when exposed to trauma. This next slide, if you look at the left side of the slide, I'm not sure if you could see it all that clearly, but these are some of the noticeable effects what the body goes through when experiencing overwhelming trauma. Pupils begin to dilate, the mouth goes dry, the neck and shoulder muscles tense, the person begins getting heart palpitations, chest pains, muscles tense, breathing can become fast and shallow, there can be hyperventilation. And those are all, if you're observing someone who's been exposed to trauma, that's the noticeable effect. The hidden effects are that the adrenaline is getting released. So all of this begins happening. And interestingly, those symptoms on the left side that we've just talked about, the physiological symptoms, interestingly, these are some of the same symptoms that people experience after a traumatic event has occurred. So for example, people can sometimes develop and oftentimes develop panic attacks afterwards. And it can be actually part of post-traumatic stress disorder. When people begin reliving the trauma via nightmares and flashbacks and can actually continue to have this heightened sense of arousal. Bottom line, trauma can lead to persistent physiological changes that affect our health, our brain functioning, and our behavior. We've just talked about some of the impact of traumatic events, but we also know that chronic stress can take a toll as well. Chronic stress can include psychosocial issues such as living in poverty, not having enough to eat, not having a support system, and the cumulative effects of things like racism and being shunned. We also know that chronic stress causes wear and tear on the body. It's associated with medical illness. It's associated with the development of inflammatory diseases, adverse effects on the brain and cognitive functioning. And it also, again, many of the people that are in the superutilizers group not only have one incident of trauma, but many of them have cumulative trauma. And for those people, it's no longer post-traumatic stress disorder, but complex PTSD, which really speaks to the severity of the disorder and also how long the person has been experiencing the effects of cumulative trauma. So we know that both stress and trauma are public health issues. We know that stress is actually linked to the 6 leading causes of death, namely heart disease, cancer, lung ailments, accidents, cirrhosis of the liver, and suicide. We know that trauma affects more than the individual. It has a ripple effect into the community. And we also know that some communities are disproportionately affected. When you have issues of bigotry and urban poverty and trauma, it leads to toxic stress. We also know that there is the intergenerational transmission of trauma, and we also know that there are things that we can do about this. I wanted to talk a little bit about a very important study that occurred back in 1998, and since that time there's been many follow-up studies on this. And this is called the ACEs study, or the Adverse Childhood Experience Study. This study ended up looking at surveying more than 17,000 people that were enrolled in the Kaiser health plan in California. and it asked questions of these 17,000 people who were adults about adverse experiences they had as children. And this included history of childhood abuse and neglect, growing up with domestic violence and substance abuse, questions about mental illness in the home, parental discord, and even whether or not a parent was incarcerated during childhood. And one of the things that that this study found was that adverse childhood experiences are very, very common. So for example, 27% of the people surveyed had had a history of family use of substance use. You can just go down this list. 28% had a history of physical abuse, 21% sexual abuse, and also emotional and physical abuse as well. So when they ended up also looking at, they tallied up all of these bad things that could happen in childhood. And if there was only one, you'd get a score of 1, et cetera. And what they ended up finding was that 2 out of 3 of these adults had experienced at least one bad experience in childhood. But they also found out that if any one of these ACEs was present, there was an 87% chance that they also had other bad experiences as well. They also found that women were 50% more likely than men to have an ACE score of greater than 5. So really what we're talking about here, and as the following slides will demonstrate, is that the more ACEs that you ended up having, the more bad experiences as a child, the more it was related to bad outcomes in adults. So for example, in this slide, it's kind of a little bit hard to see, but if you had an ACE of 4 is considered to be pretty bad, and on this slide, if you had an ACE of 4 or more, it was associated to the later development of smoking behavior. If you ended up having a childhood history of family alcoholism, it was associated, excuse me, let me say that. If you ended up having an ACE of 4 as a child, it was related to you developing adult alcoholism by a lot, as you can see by the pink bar graph there. So again, high ACEs were related to smoking as an adult and alcoholism. It also was related to predicting that you as an adult would go on to develop injection drug use. Also, an ACE of 4, again, these are all childhood experiences that later predicted a high increase in suicide attempts as an adult. So with an ACE score of 0, the majority of adults have few, if any, risk factors for alcoholism, suicide attempts, substance abuse, smoking. However, if you have a score of 4 or more, the majority of adults have multiple risk factors for these diseases or the diseases themselves. We also know that these adverse childhood experiences rarely occur in isolation. They come in groups. And what we mean by that is that if someone had a childhood history of a parent having drug abuse or alcohol, or a parent was incarcerated, it also ran in clusters, so often the child was exposed to childhood physical abuse or neglect. So these things tend to come in clusters. And so then it brings up the question, how does trauma affect the individual? Well, we know that trauma shapes the survivor's basic beliefs about themselves and others. So you are now an adult and you've had all of these bad things happening in childhood. It basically changes your worldview. It basically makes you believe that the world is no longer safe, It makes you not trust other people. It makes you become perhaps guarded with other people, needing to protect yourself and put up a lot of defenses and not believing in anything. And we know that violence robs people of a sense of safety in the world. It pretty much shakes people to their very core. It disrupts people's lives and their relationships. It damages the spirit. It changes our basic sense of the world. Now, it is possible that you have not had a lot of bad things happen in your childhood, but as an adult, you get into situations where perhaps you've been sexually assaulted or you're in a domestic violence situation. And even adult onset trauma can end up affecting you and affecting your worldview. We know that trauma damages basic capacities, the basic capacity to trust. It could either be people begin not trusting anyone, or they begin to become too trusting. And that's an interesting type of thing. Why would people who have been exposed to cruelty and violence, why would they become too trusting? There's some thought that it's people's way of trying to cope and master with a bad experience. But you're beginning to get a sense from what I'm talking about. Some of the other basic capacities are things like emotional extremes. People with chronic trauma and complex trauma sometimes have difficulty managing their emotions and feelings. They may present to others with intense affect. They may be very emotionally labile. They may have hyperarousal. They may have flashbacks and nightmares. They may have an increased startle response. They may end up having periods of disassociation, which means that they're cut off from experiencing things in the world, and they may also experience self-harm. And a lot of times, some of the superutilizers that we work with may present to paramedics, they may present in the emergency room, they may have help-seeking behaviors, and sometimes they're very difficult to engage with because on the surface, they may appear to be, at times, maybe belligerent or overly dramatic. They may be demanding, and in that way, they may push us away, people who are trying to help them. We also know that trauma damages relationships. It can lead to boundary issues. It can lead to having people have a difficult time assessing who's safe in their world. So it may explain why you have someone who goes from one domestic violence relationship to another. People basically lose the ability to judge who is safe in their life, and they actually may end up reenacting the same situation over and over again and continuing to put themselves in danger by getting involved in high-risk behavior. We also know that, just as I've mentioned, trauma impacts behavior, may have inappropriate behavior, overreacting, aggression, failure to connect cause and effect, maybe have some depression and anxiety, self-destructive behavior, fear and vulnerability, feelings of worthlessness. We know that the rates of the prevalence of trauma history, we know that the rates are higher in populations with severe mental illness. 98% of severely mentally ill clients report at least one type of traumatic event in their lives. We also know that 51 to 97% of women, severely mentally ill clients, report sexual or physical assaults during their life. And we also know that approximately 1/3 of seriously mentally ill clients report physical or sexual assaults in the past year. This is not to say that everyone who's had a traumatic event goes on to develop serious mental illness, nor is it to say that everyone with serious mental illness have trauma, but there is certainly a comorbidity that occurs with both. We also know that people at risk for developing PTSD tend to be people in underserved populations. Patients served in the public sector have additional risk factors. They have a lack of social support. They may have high adverse childhood experiences, low socioeconomic status, limited education, and many may also have a history of psychiatric disorder. We also know that PTSD and substance abuse often co-occur. And so, for example, oftentimes it's thought that PTSD symptoms may precede the evidence of, may precede the symptoms of substance abuse, and that people who have PTSD symptoms may go on to medicate their symptoms by abusing alcohol and substances. I'm going to go through this pretty quickly. So there is definitely a link between PTSD and substance abuse. The main themes in both disorders can be secrecy and control. Each of the disorders makes the other more likely to occur. And we also know, continuing with this, we know that being abused or neglected as a child increases the likelihood of being arrested as a teenager by about 59%. We know that arrest rates of trauma-exposed youth are up to eight times higher than community samples of same age peers. So this, given all of this, and given the fact that we have the co-occurrence of between domestic violence, alcohol abuse, substance abuse, childhood neglect, we have all of those kinds of things, and we know that they are related to increase in health risk factors, and we know that many of the people who are in the subutilizer group have histories of trauma. It becomes really important that as we approach people who may be cycling in and out of medical facilities, maybe cycling in and out of jail and treatment facilities, that we need to be able to develop a system for providing trauma-informed care. And when we talk about trauma-informed care, we're talking about a trauma-informed care approach that is an approach to engaging people with histories of trauma that recognizes the presence of trauma symptoms and acknowledges the role that trauma has played in their lives. So the trauma-informed approach, recognizes the widespread impact of trauma, and it also understands potential paths for recovery. And I want to say something about that. As someone who has worked with victims of violent crime for a long time and people who have really experienced a lifetime of trauma, I really, really do believe that when treated in a trauma-informed way and being treated with evidence-based approaches, that people can get better and that people are tremendously resilient, and that we talk about post-traumatic stress, but we can also talk about post-traumatic growth. And I think it's just so important in the work we do that we recognize that we can play such an important role in people getting better, and that there is hope, and that, in fact, we oftentimes, people who've been exposed to trauma oftentimes have given up a sense of hope in their world. They can't believe their lives can be any different. And we oftentimes are the holder of hope for these clients that we work with. And by providing a trauma-informed system of care and holding on to that hope, we can get to the point where we can transform that hope onto our clients themselves so that they can begin the journey to recovery. The trauma-informed approach recognizes the signs and symptoms of trauma in clients and in families. It also responds by fully integrating knowledge about the trauma into policies, procedures, and practices, and it seeks to actively resist re-traumatization. So trauma provides the context for behaviors. Traditionally, and I will say traditionally, as a mental health provider, sometimes mental health providers approach the clients and the patients we work with from the stance of, what is wrong with you? Kind of a judgmental approach. And really, from a trauma-informed approach, the question is really different. Instead of, what is wrong with you? The question is, what has happened to you? This is a little bit difficult to see, but some of my colleagues that I work with in primary care developed this slide to talk about the importance of screening, asking people about past, current, and lifelong history of trauma, coming up with a way of training staff on a compassionate way to respond when we know people have a trauma history, by building in our organizations a foundation to provide compassionate care, and also creating an environment, even a physical environment, where we are providing a safe place for people to be. So this comes from SAMHSA's 6 key principles of a trauma-informed approach. And one of the principles is safety. And that, whatever setting we're working in, it's important to make sure that the patient or the client feels safe when they come to us. Sometimes this can be provided by making sure the client feels safe coming to the work site, helping to resolve any concerns that they may have. It may also be establishing and maintaining clear boundaries with clients and doing so in a clear, non-punitive way. One of the things about safety, and I know we may do this in our various work settings, but if you look around your work setting and look at it with a very critical eye and look at the kind of signs that are around. So you walk into some places and there are signs all over the place. Do not lean on the glass, do not do this, do not do that. So there's all of these messages that are not very welcoming to people. And so creating a trauma-informed environment may even be taking a look at the physical surroundings. When we talk about creating trustworthiness and transparency, if this is someone who's used to betrayal, who's used to being disappointed, who's used to being taken advantage of, you in the position of being an authority perhaps with this person, it's really important that you deliver on what you say you're going to deliver. That means being on time for appointments, not canceling appointments. If you say you're going to help them with something, to follow up on it. Deliver on what you said you would do. And this is a way of building trust and engaging with the person. If policies or rules for the agency are going to change, let the client know ahead of time. No surprises. It's also important to develop giving people as much as possible a sense of empowerment, voice, and choice. If you can give clients a choice in terms of when their appointments may be or their location of services, that's helpful. And also soliciting feedback from people around how they are accepting or receiving your services. And of course, being really sensitive to the cultural, historical, and gender issues that might come up. So one of the things that we've been working on in San Francisco is developing the trauma recovery model of care. And this is something we've been working on for a while. And I say for a while because it's taken us a long time to figure out what our clients need. And I know for sure we still haven't quite figured it all out. It's all a work in progress. But I will tell you from the very beginning, one of the things we realized was that a traditional mental health or psychotherapy model for trauma victims is not sufficient and it is not enough. And when we talk about traditional psychotherapy, we're talking about an office-based approach that does not do outreach in the community, does not do home visits, that does not help the individual by providing any kind of practical assistance, tends to be a 50-minute session, tends to be feeling, insight, and disclosure-oriented, and tends to have that approach that I was mentioning before, what is wrong with you? It's not surprising that many of our clients and many of our super utilizers do not want to get into mental health treatment and that they don't trust that it will help. And there certainly is a great deal of stigma around mental health, accepting mental health treatment. So part of what we've been working on is really developing a different model of care where the emphasis is on assertive tracking, outreach, and engagement into services. And by that I mean really engaging people in a way where you build trust, doing it a step at a time. If people can't come to us, we go to them. We do home visits. We do outreach in the community. We also recognize that part of the impact of chronic trauma are not only mental health symptoms, but people have a lot of practical needs as well. And those practical needs may be help for safe housing, dealing with even filing a police report, dealing with law enforcement, getting medical care, and other legal assistance. And also it includes providing evidence-based psychotherapy. And this gets back to what I mentioned before. In using evidence-based treatment, and what we mean by evidence-based treatment is that treatment that has been proven to work over time by research protocols that demonstrates that this is a set of interventions that work with a particular population. And we do know that the good news on the horizon is that we know that there are certain evidence-based treatments that particularly target PTSD and chronic post-traumatic stress disorder. Again, the engagement and tracking recognizes that many of our survivors feel ashamed about entering therapy. We try to work on what's most important to them. We will see them at the hospital if they're an inpatient, at their home, or in the community. And I'm going to go through this very quickly because I think I'm about out of time, but the outcome of the TRC model shows that people are able to engage with our services. 77% of survivors that were assigned to TRC engaged in mental health services compared to only 34% that were assigned to customary care. We increased the rate from sexual assault victims receiving mental health services from 6% to 71%. I'm just going to go through this pretty quickly. PTSD symptoms decreased by 38% over just 16 sessions of time, and depression decreased by 52% over just 16 sessions. And the TRC model costs 34% less than usual care. I think I'm going to end at this point, and we can open it up for questions in a little bit.
All right. Morning, everyone. My name is Keith Kaiser. Again, I am the Crisis Intervention Team Coordinator and CIT Grant Administrator for the Lake County Sheriff's Office. I took over these programs in November of last year, so I'm still in the process of learning about the mental health community and trying to improve our crisis intervention team. Since I've been put into this position as the CIT coordinator, I've recognized the need for CIT training and the positive impact that it's having on our communities. Today I'm going to discuss the background of the crisis intervention team in Lake County, what we are doing now, and where we want to be in the future. So first, for those of you who are not familiar with Lake County, we are in the far northeast corner of Illinois. Depending on where you're at in the county, you can be between 15 and 45 minutes from Chicago. The population of Lake County is just over 700,000 residents. We're the third largest county in Illinois, and the Sheriff's Office has jurisdiction over 130,000 residents in unincorporated or contracted service areas. Lake County is an extremely diverse region. We have several urban areas and few rural communities. We see some very wealthy areas and some poor areas of the counties. We have two communities in the county that are only 3 miles apart, and they have a median household income disparity of $112,000. The wealthy community has a median household income of $150,000, and the other community is at $38,000. Just for a reference, Chicago's median household income is roughly $6,000. Lake County is home to 11 Fortune 500 companies, and we have several local attractions like Six Flags, Gurney Mills, Fort Sheridan's Army Base, a VA hospital, and the Naval Station Great Lakes. We estimate 34,000 residents in Lake County are veterans, which we could attribute partly to the Naval Station and the VA hospital. Our homeless population is estimated to be at 300 people from an annual point-in-time count, and 9% of our residents live under the national poverty level. At the Sheriff's Office, we employ 580 employees. 200 of them are correctional officers that work in the jail, and 200 are law enforcement officers. Altogether, in Lake County, there are 1,350 police officers. The daily population of our jail fluctuates around 600 inmates. And the Sheriff's Office began sending officers to crisis intervention training in 2005. And we'll talk about that in a second. So what is crisis intervention? At the Sheriff's Office, we define crisis intervention by saying it refers to the methods used to offer immediate, short-term help to individuals who are experiencing an event that produces emotional, mental, physical, and behavioral distress. It's a known fact that individuals with mental illnesses and substance abuse disorders are more likely to be incarcerated than the general public. Because us as law enforcement are often the first to get a call for help, we tend to be the first line of government help when you call at 2 o'clock in the morning. It's essential for us to have a wide range of skills. We're often part-time social workers, psychologists, babysitters, nurses, teachers. Sometimes we do have to write tickets and take people to jail. With that being said, it's an inherent responsibility of law enforcement to deal with those individuals with mental illnesses and substance abuse disorders. Whether they call us for help, we see someone break the law, or someone is alarmed by their behavior, we have an obligation to investigate and provide a conclusion. Crisis intervention team training was established to help police officers react appropriately and to properly assess situations involving mental illnesses, developmental disabilities, or emotionally disturbed persons. In most cases, we do try to provide alternative outcomes to those persons rather than potentially taking them to jail where they're not going to receive the proper clinical or psychiatric care. The notion of CIT training and similar law enforcement programs is aimed to change the mindset of police officers as the warrior who fights for civility to the notion of a guardian who's there to protect the needs of the community. So what was our problem in Lake County? We tried to define what we were doing wrong and what we could change. The national studies estimate 10% of law enforcement encounters have interactions with persons with mental disorders. So this is pretty easy, and I can do the math. the Sheriff's Office responds to about 200,000 calls for service every year, so we estimate that then 20,000 of our encounters are with people with mental disabilities. That seems like a lot, 20,000 encounters, but when you sit back and think about it, it does make sense. A lot of our time is spent helping persons with mental disabilities. A nationwide study show that 15% of those incarcerated have a serious mental disability. The number of inmates with non-serious mental disabilities is far greater than 15%. With funding cuts and services not available from that traditional funding, we find ourselves interacting with more people with mental illnesses who aren't receiving the proper services. Some are committing crimes and landing themselves in jail. We did a survey in the Lake County Jail in 2015, which showed that 41% of our inmates had been booked into the jail previously within the last 3 years. So based on those national averages, several of the people that were arrested and rearrested would have had mental disabilities. And earlier I said that crisis intervention team concept started in 2005 for the Sheriff's Office, and that's about all that we did. We sent 20 employees to CIT training, 16 were deputies and 4 were correctional officers. But we never followed through with the implementation of the program. The deputies were not utilized properly, and there was no formal policies or procedures that we put into place. And then we didn't send anyone to CIT training again for almost 10 years. So of those 20 people that we initially trained, only 4 of them are still employed with us today. Most of the employees didn't have CIT training, so they had a lack of knowledge and skills when it came to dealing with persons in crisis. So we were asking our deputies to walk into a critical crisis situation with no formal training or direction. The informal training was to either take the person to jail for something or send them to an emergency room. Sometimes the easiest thing to do is to take someone to jail. With the CIT training that I've received, I look back at my career and I can recognize that I have made mistakes. I've taken people to jail, sometimes over and over again, not because it was unlawful or because I didn't have probable cause, but I didn't make the right decision, especially in those cases where we had the repeat consumers. It only solved a temporary problem, and I guess that a lot of those cases were dismissed by a state's attorney. And, I look back, too, in some of the cases I was able to recognize that the person had a mental illness, but I did nothing about it. I didn't look for a root problem to their actions, and I didn't know what options I had available to me, and I didn't know what services were available in the area. With that being said, I recently heard a phrase that says, "You don't know what you don't know." So we were trying to help people that we serve in the community, and we at the Sheriff's Office didn't know what resources we had available in our area to help people in crisis. So now we have a document with 3 full pages of different resources that are available to police officers to help the citizens in our communities. So what have we done now? In the last few years, our county has recognized a need for local crisis services and additional crisis intervention training for police officers. Representatives from our Sheriff's Office went to the county board, and we've appropriated $30,000 annually for crisis intervention team training. We've additionally created policies and procedures to implement the CIT program. We specifically dictate in policy that if a CIT officer is available, they should be dispatched to any call where there's a potential mental health issue, or if a dispatcher on the phone determines that the call involves a person in a crisis. The policy also dictates reporting instructions and the completion of a mental health crisis report. We've also recognized that our deputies are not the only employees who contact persons with mental illnesses or substance abuse disorders. Our corrections officers obviously encounter these individuals that are brought into the jail, and our court security officers deal with the individuals while they're in our courthouses. But we've also begun training our 911 dispatchers, hoping that the training could help identify a crisis prior to the deputies arriving, and hope that they could help with the crisis while the deputies were on their way. We've also begun training our clerical staff because we see the same people that we're bringing to jail are the same people whose homes we are at during the crisis. They're the same people who are in the jail, and they're the same people who are in our courts. They also come into our offices requesting police reports or looking for additional information. So currently we have almost 100 CIT trained employees at the Lake County Sheriff's Office. And a quick story that I'd like to interject is that since we started our CIT training with our clerical staff, we've had 2 suicide attempts in the lobby at our headquarters in Waukegan from residents from a nearby group home, which were initially handled by clerical staff, where they were able to identify the problem and get police officers and then the EMTs in there so that we could help these individuals. And at the core of our CIT training is building partnerships with local mental health providers. The county has established a mental health coalition, which involves key stakeholders from hospitals, homeless shelters, drug abuse treatment centers, lawmakers, law enforcement officials, state's attorneys, and judges. All of these stakeholders have policy and decision-making abilities. Then the Sheriff's Office has created a mental health committee with a more hands-on kind of mid-level stakeholders. Both of these groups meet regularly throughout the county to discuss the progress and identify gaps in services, try to improve the overall product we're putting out. The Sheriff's Office, we've also begun some public education programs. Last year we held 5 town hall meetings. At each of the town hall meetings we've discussed our CIT program. Additionally, our communications section created a short video that we air on the county's television channel and posted on various web pages. We have several occasions now where people call the Sheriff's Office and specifically ask for a crisis intervention officer to come help their family or some other person in crisis. We also have municipalities within the county, police departments that call and ask us to assist with a crisis situation with a CIT officer. And the largest step that the Sheriff's Office and that Lake County took was that we applied for a Justice Mental Health Collaboration Program grant from the Department of Justice. This is a collaborative endeavor that we've had with the County Administrator's Office and the Lake County Health Department and NICASA, which is a service provider in the county. And last year we were awarded the $250,000, and the grant is currently in its planning phase. So this grant addresses several topics and specifically 3 main areas. The first is that we want to be able to train or pay for the training of 395 police officers throughout the county, which will bring us to about 40% of officers in the county having CIT training. The next thing that we want to do that's very important is to track the interactions of the CIT trained officers throughout the county, not just the Sheriff's Office. This is going to be tricky because we need cooperation from municipal police departments to turn that data over to us to make sure that we're tracking the correct data that everybody is looking for cooperatively. And then to track that data, we need to find some sort of common platform to enter the data and track relationships between the data. We plan to track data such as the location, time of day, the type of crisis, living arrangements for the person, whether they're homeless or live in a group home or live in a residential home, whether or not they're a veteran, are there co-occurring disorders, do they have alcohol or substance abuse issues, have we had prior contacts with them, and then have any of those prior contacts occurred within the last 24 hours, and whether or not the outcome that how we leave them was with a service referral, an involuntary or voluntary committal to a hospital, or an arrest. We're also looking to track whether or not there are injuries to either the police or the consumer, and did we have to use any force against the individual, or was force used against us? And lastly, part of the grant is common to the core of CIT is that we want to familiarize deputies and police officers with the behavioral health resources and services that we have in our area. So where do we want to be? One of our main goals at the Sheriff's Office with crisis intervention team training is to reduce the incarceration of the mentally ill and be able to provide them with positive interactions and connections to service. We don't want our jails to be holding facilities for the mentally ill. Another project that we have in the works relates to our super utilizers. The jail has received a MacArthur grant to identify some of our super utilizers. We plan to identify 30 individuals with a mental illness and a few other characteristics who have been incarcerated at least 3 times within a year. We're then planning on working with NICASA, which is that local service provider, who will be able to provide services or lead that person to services such as substance abuse or psychiatric care. Us and the provider will try to track their progress and try to keep these people out of jail by keeping tabs on those 30 individuals. This is going to be an interesting endeavor, and we are hoping that we can have positive results on those 30 people so we can try to move it to a larger program. Another goal of ours that we want to do is establish a local CIT training host site, and that's something that we are very excited about. We've been meeting with representatives from the College of Lake County to establish a Law Enforcement Training and Standards Board certified CIT program. We're working with the college's Department of Social Work and Professional Development, and they are working diligently on a curriculum, and hopefully we'll have a certified class soon. A local CIT class will help provide the officers with those local resources we're talking about and consistent practices throughout the county. We also want to be able to integrate community and healthcare providers into the training. We want to be able to have as many people as possible receiving this CIT training, not just law enforcement. At one of our town hall meetings, someone was asking me a lot of questions about CIT and what steps that we were taking towards it. And I asked this person how much why they knew so much about CIT, and I thought that the answer was going to be that they were related to a family member with a mental illness, but she told me that she was a librarian and she had taken a SAMHSA class on mental illness. And this was kind of an aha moment for me because I realized that several homeless people, usually with mental illness, spend their days at a library because, you know, obvious reasons. It's warm, it's dry, and there's restrooms inside there. So we want to be able to teach those people with the same skills that we're looking for to try to help to be another first line of defense. So we'll train librarians, firefighters, EMTs, you know, security guards, whoever wants to try to make a difference. And then the College of Lake County also plans to add CIT into its curriculum for students, which I think they're excited about as well. We want to have consistent county-wide policies relating to CIT and the tracking and evaluation in place, which I think that we'll be able to use kind of MOUs with these municipalities to make sure that we're providing them with training and that we receive information back for the tracking and evaluation. And we'd like to have the tracking and evaluation on a web-based program or even a phone app to make it easy for the officers on the street to turn in that data that we're looking to compress. And then another issue that that is big right now is that we want to be able to share our information with service providers. Right now we're trying to implement a system which will allow a deputy who's on scene of a CIT call to call the health department's crisis hotline and provide them with information. For example, we can tell them the symptoms the person is experiencing, and they may be able to provide some assistance or lead us down the right track of what assistance or services are available to the consumer. And then we're also looking to possibly set up a database so that they could tell us when the person has an appointment, if it's scheduled with them or other service providers, so we can try to make sure that the person gets to the appointment or see if we can get an appointment scheduled earlier for the person. And then we've begun talking in the county about plans for a local drop-in center at at some point we would be able to develop partnerships for some sort of mobile response team that could also help us with some follow-up services like getting people rides to treatment and checking up on people that haven't shown up for their appointments. And so I wanted to be able to share some of our success stories today. Deputy Katie Gordon has a great story which we have been telling. She wasn't able to be here today, so this is the short video I spoke about before that our communications department created for CIT to show our successes with Deputy Gordon's story. So if somebody can take that over, there we go. Thank you.
We are in the College of Lake County, Milwaukee campus, and the reason that we're here, the Lake County Sheriff's Office, is spearheaded a county-wide law enforcement first response training called CIT. CIT refers to Crisis Intervention Training, which is a very, very significant tool to discover the good correlation to mental illness, drug addiction, and homelessness. And those three groups tie together. Once we've identified mental health and drug addiction and situations start to escalate, this training will allow us now not only to identify these folks, but to de-escalate situations.
Crisis intervention training is a 40-hour training, which is a week-long training, where professionals come in to teach police officers and administrative staff techniques and talking to people with mental illnesses and behavioral disorders, where you learn to recognize the signs and symptoms associated with those behaviors and disorders and how to deal with those the signs and symptoms, how to respond to those with alternative techniques, getting people to the right resources rather than incarcerating them.
I responded to a domestic between the father and the son. The son was autistic. He is also diagnosed with oppositional defiance disorder, as well as other anger issues. So when we got there, we had learned that the son was better for the dad. He chose the dad, and the son was extremely agitated when we got there. We spoke to him, calmed him down a little bit, and then I went and spoke with the parents, and I asked about his mental health history, his medications, that type of thing, and they were kind of surprised that that's what I was asking about, instead of more of the time that took place. We spoke, and I learned he had been on his medication for a rather long time. They couldn't tell me how long he had been on it. So I kind of noticed that he needed to have something adjusted with his medication. So I spoke with the son, and he realized that this wasn't normal for him, and he needed something adjusted. So voluntarily, he went to the hospital for a voluntary petition. And then about a week later, I went back to check on the family, see how everything was going, and I knocked on the door, and the parents were kind of surprised to see the police back at their house. They didn't call us. We went in and talked, and they said that the son went before a doctor, got some new medication, and everything had been perfect after seeing the new doctor. And I went to leave, and I'm like, all right, great, call us if you need us. And the mom stopped us, and she said, thank you. Thank you for digging into what was going on instead of just looking at the situation. But she was very appreciative that we were able to do that. The excellent information, because before this training, I would go to calls, and you could see that someone had a mental illness issue, but you had no idea what you could do for them. Nothing. So this is better for communication. We're able to communicate with people a lot better, and people are noticing on the street that we're doing things differently. We're changing the way we're doing business, and people enjoy it.
All right. I'd like to thank everybody for listening, and sorry we went over by a couple minutes, but if anybody has any questions or suggestions for our program, my contact information is up here. And thank you.
So, yes, as Keith mentioned, we've run a little long. We've had some amazing information presented to us today. We did have one question in the chat bar that I would like to raise, and that was, where would you suggest agencies go to access CIT training? Keith, I wonder if you could address that.
Well, the CIT training in Illinois is it's difficult to find a provider for it, and what we have been doing is is we've been paying for it with that $30,000 we got from the county board to get a provider to come in and teach the courses for officers, and we've been opening that course up then for municipal police departments within Lake County at a discounted price. But that's why we're trying to establish a local training host site to provide more frequent training and cost-effective as well. But the Illinois Law Enforcement Training and Standards Board does have a nice website with CIT related classes and information about where classes are being held. It's just a lot of them are full the minute that they go up onto the website.
And we can post a link on the Illinois Data-Driven Health and Justice website that will have a link to the Illinois Training and Standards Board where these CIT classes are posted. Also, this presentation will be posted on the DDJ website pretty soon after this, and you can feel free to contact both of our presenters. Their contact information is here at the end of the slide. We want to thank everyone for participating in this webinar, and for more information on the Illinois Data-Driven Health and Justice project, including recordings of previous webinars and online resources, please visit www.icjia.state.il.us/DDHJ. Thank you very much.